This is a reflective practice on the inability to secure the opportunity to perform an ultrasound-guided peripheral intravenous cannulation. My name is Perphl, and I am a registered nurse within the Oncology Day Therapy Unit at the Royal Brisbane Women's Hospital, Hurston, Queensland. Through this reflective practice, I will outline reasons as to why there was not an opportunity to practice the skill of ultrasound-guided peripheral intravenous cannulation, PIVC, and thoughts and feelings experienced having encountered obstacles in performing this skill. I will also provide an assessment on implications brought about by lack of opportunity to develop the skill of ultrasound-guided PIVC, present evidence demonstrating benefit of implementing ultrasound-guided PIVC, and propose means by which the impediments to training in ultrasound-guided PIVC may be overcome. Finally, a course of action by which I may achieve practical experience in ultrasound-guided PIVC and advocacy of same for myself and colleagues will be discussed. The opportunity to perform ultrasound-guided PIVC did not present in the 6-week period following the workshop. Discussions occurred with the nurse unit manager and the assistant nurse unit manager, followed by email communication including details of the online modules and workshop activities completed. Subsequently, advice was received advising that it would not be possible to undertake practical completion of ultrasound peripheral cannulation due to the limited time available. The practical performance of ultrasound-guided PIVC would need to be conducted by another department which manages and performs this for the whole of hospital. An inability to provide offline time to complete the practical exercise, and the nurse manager for the service providing ultrasound-guided PIVC was on work cover leave. It should also be noted no ultrasound machine is available within the department where I work. On considering the situation whereby I have been unable to fulfil the supervised practical execution of ultrasound-guided PIVC, I was initially despondent from encountering barriers to acquiring a new skill. I was also frustrated at the lack of options available to acquire the new skill, and fearful over the potential loss of knowledge as time passes from completion of the online modules and workshop and the unspecified future timing of the supervised practicum. I then became resolute to make every endeavour to progress the process and realise the final step in acquiring competency in ultrasound-guided PIVC. One of the main barriers to acquiring this skill of ultrasound-guided PIVC is the lack of opportunity to undertake the practical training. This is due to a number of factors. Work demands on the department. The department is a very busy ambulatory outpatient setting, performing over 100 occasions of service each day. Staffing. There are additional demands placed on the department when sick leave is experienced, reducing the availability of nursing staff and the opportunity to perform offline educational activities. Equipment. It has been indicated that the department is intending to acquire an ultrasound machine for use for peripheral cannulation. This has not occurred and is therefore reliant on the service provided by another department to perform ultrasound-guided PIVC. Implications and risks to those individuals assessed as divas as a result of these barriers include that divas may be confronted with multiple attempts to establish peripheral venous access. Divas are exposed to unnecessary stress and trauma in anticipation of and during PIVC. Treatments are delayed due to the additional time taken to establish peripheral IV access. There is compromise to venous health preservation from repeated attempts to establish peripheral IV access. There is increased potential of peripheral intravenous cannula failure, causing additional trauma, interruption to therapy, reduced dose administered, and potential permanent harm and disability. In addition, there are additional healthcare costs incurred for the time and resources required in performing multiple attempts to establish peripheral IV access. Organisational culture and leadership recognise the benefit of ultrasound-guided PIVC and have indicated the intention to acquire an ultrasound machine for use in the co-located apheresis department. However, for reasons not provided, the ultrasound machine has not arrived. This delay may be due to a number of reasons, and funding may be one of them. Nursing management are aware that the lack of an ultrasound machine does incur delays to treatment start times, which has a flow-on effect in a very busy ambulatory outpatient setting. However, the nursing team are constantly assessing individuals for peripheral intravenous cannulation and patient reporting and/or evidence of repeated attempts would initiate escalation to medical officer for review for central venous access device insertion based on individual assessment. Ethical considerations around equitable access to ultrasound-guided peripheral intravenous insertion are addressed but could be improved. The lack of access to an ultrasound machine and nursing staff trained in its use within the department limit the standard of care available to individuals presenting for treatment. When an ultrasound-guided PIVC is booked, a wait time is experienced as the department providing this service has limited staff and serves the whole of hospital. The impact of this wait time is not limited to treatment delivery, but affects subsequent appointments for the patient, that is, radiation therapy, X-ray, and also patient transport. This creates further stress on the patient, personnel, and the department as endeavours are made to provide all treatment in a timely manner. Impediment to change may occur when learning a new skill or way of doing things is encountered, as there may be concern over learning to interpret ultrasound images and inserting a cannula using the ultrasound image as the guide. Skepticism as to the benefit of the transitioning to ultrasound peripheral venous cannulation may be expressed with the time involved in preparation used as comparison, but if measured in context of one attempt versus multiple attempts, the comparison is moot. There may be caution over the accessing of deeper veins under ultrasound-guided PIVC for the use of cytotoxic agents. Concerns are often reported over the difficulty in monitoring for extravasation and phlebitis in deeper veins. Potential benefits: higher success rate on first attempt of PIVC, improved patient satisfaction through reduced attempts and reduced likelihood of complications, timeliness of treatment delivery, and promoting venous health preservation. Evidence in support of efficacy of ultrasound-guided peripheral venous cannulation can be found in a systematic review by Patterson and others. In this review, they found unanimous recommendation for use of vessel visualization technology in patients classed as or potentially difficult for peripheral cannulation. Tian and others in their systematic review titled Intravenous Catheter Placement by Nurses, a systematic review and meta-analysis, found ultrasound-guided PIVC insertion to be safer, faster and more effective, with a reduction in number of skin punctures to achieve successful peripheral venous access. This had particular relevance for patients identified as DIVA. Potential role of interdisciplinary collaboration in addressing barriers to training and supervision opportunities may be achieved through nursing research covering ultrasound-guided PIVC insertion and including patient-reported experiences, cost and time analysis. Promotion of increased adherence to reporting by clinicians to safety and quality of adverse outcomes and incidents in standard PIVC insertion. Reviewing current clinical guidelines and policy to include evidence-based use of ultrasound-guided PIVC insertion as a first call for DIVAs and those suspected of being DIVA. Repeated advocacy promoting Cancer Nurses Society of Australia position statement titled Peripheral Intravenous Cannula Insertion Procedure Using Assisted Visual Technology, including ultrasound and near-infrared technology, highlighting the importance of ultrasound-guided PIVC insertion as a first approach rather than a rescue strategy. Promote benefits of using ultrasound-guided PIVC insertion, including improved patient safety, time and treatment delivery for DIVAs, and increased patient satisfaction. Although barriers to undertaking ultrasound-guided PIVC exist, these may be addressed through ongoing advocacy for this procedure to become integrated within the department's service. This may be addressed by conducting nursing research looking at the benefits of ultrasound-guided PIVC insertion, including increase in patient satisfaction. With evidence-based practice guiding procedure, further research would benefit the argument in support of adopting ultrasound-guided PIVC insertion with the focus on nurse experience, patient satisfaction, and cost analysis, including review of time saved. As an action plan to assist me in acquiring the skill of ultrasound-guided PIVC, I will include training in ultrasound-guided PIVC in my performance development and planning document, which is reviewed annually, and continue to pursue hospital service-based education sessions in ultrasound-guided PIVC insertion. Thank you.